For molecular therapy, we have some specific gene alterations in meningiomas that have been studied. So the main three ones are inactivation of the tumor suppressor gene of neurofibromatosis 2, and this was established as a driver in about 50% of sporadic meningiomas. Then we have the Merlin gene that plays a role in the activation of mTOR pathway during the pathogenesis of meningioma. And consistently, overexpression of mTORC1 pathway components has been reported in meningiomas. Finally, focal adhesion kinase inhibition may be another promising avenue in NF2 altered tumors. Moving to molecular targets, we have some frequent mutations in meningiomas, being, for example, POLR21A mutations that are seen in WHO grade 1 meningiomas. Then we have the ubiquitin ligase tumor necrosis factor receptor associated factor 7, TRAF7, that is mutated in approximately 20% of WHO grades 1 and 2 meningiomas. We have also seen mutations in the Kruper-like factor 4, KLF4 gene, which are exclusively seen in secretory meningiomas. And finally, we have also seen telomerase reverse transcriptase or third promoter mutations which are associated with aggressive meningiomas. And finally, with immunotherapy, what's new is that the expression of programmed death ligand 1, PDL1, was increased in WHO grade 3 meningiomas. So this being said, it has been seen that higher numbers of PDL1 expressing cells have been associated with a worse overall survival. So an immunosuppressive microenvironment might contribute to the malignant phenotype of meningiomas, and this is what has been made for immunotherapy advances. So finally, talking about some recommendations. First of all, patients should be made aware of all possible treatment options for primary and recurrent disease. And challenging cases and multiply recurrent cases should be reviewed with a multidisciplinary team. Development of a core outcome set that includes intubation complication rates, epilepsy, cognitive function, and health-related quality of life will ensure that meningioma trials report outcomes that are relevant and important to both patients and clinicians. And clinical trials should continue to stratify patients according to relevant biological subtypes of meningiomas defined by mutational and epigenetic alterations. And finally, rapid cycle translation from discovery and preclinical testing to clinical trials is needed to promote research on therapeutic advances in meningiomas. And that's about it. So if someone wants the article, just feel free to email me, and I should be able to share it with you. Thank you for your attention.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.